Thank you for joining us for our third Echo for PWS session, PWS and Sleep with Dr. Amee Revana. My name is Stacy Ward. I'm the CEO for PWSA USA, and joining us from the PWSA staff is Lynn Garrick, the Medical and Research Coordinator. Before we begin, I'd like to share a little information about ECHO for those of you who may not be familiar with this model. ECHO stands for Extension for Community Healthcare Outcomes, and it was established in 2003 at the University of New Mexico. There's 4 guiding principles of ECHO: amplification, which is using that technology to leverage scarce resources; share best practices to reduce disparity; apply case-based learning to master complexity; and to evaluate and monitor outcomes using a web-based database. So some common phrases that you might hear in ECHO sessions or when you learn about ECHO, there's 2 of them. One is moving knowledge instead of moving patients. So the idea is to bring that knowledge to where your patients are rather than asking patients to travel throughout the country to get the medical care that they need. The other is all teach, all learn. So following the Project ECHO best practices, I'm going to ask that everybody share their name, their title, and their location in the chat. And if possible, I understand everybody is very busy and doing other things, but if possible, if you could turn on your camera, at parts of this presentation, it is going to be a conversation. We're hoping that you will participate and ask some questions. Very quickly, let me introduce you to Dr. Revana before she takes this over. Dr. Revana is a triple board certified pediatrician, general pediatrics, pediatric pulmonology, and sleep medicine. She has a strong interest in general pulmonary diseases such as asthma, chronic lung disease, and prematurity, as well as in sleep disorders such as obstructive sleep apnea, insomnia, narcolepsy, hypersomnia, circadian rhythm disorders, and restless leg syndrome. She enjoys working with children of all ages and is dedicated to helping children and their caregivers as a team. She's actively involved in teaching trainees in pediatric pulmonary and sleep medicine. Her research interests include home sleep apnea testing in children, Prader-Willi syndrome, and narcolepsy. Dr. Revana, thank you so much for being here. I'm going to give it to you to take over.
Thank you for having me. I feel extremely honored to have the end of the day and as everyone's finishing up their day and trying to get home and whatnot. So I'm super grateful to spend time with you today. The title of the talk is Diving into Disease in Prader-Willi Syndrome. I have a special heart in this because I've spent several years now learning about it. And so here I'm going to share a little bit about at least an overview of Prader-Willi syndrome and sleep. Feel free to interrupt with questions. I'll try and multitask with the chat as well to keep up. Here are my financial disclosures. We won't be talking about specific trials and whatnot. I will defer those to another time. But mainly, the objectives for tonight is that we'll briefly discuss normal sleep patterns in typically developing children in comparison to children with Prader-Willi syndrome. We'll list 3 common sleep disorders, or at least the top 3 in Prader-Willi syndrome that we commonly see or think about when you come to the sleep clinic for an evaluation, along with diagnostic tools and treatment modalities available in this patient population. So I'm going to start off with a case. This is pretty much usually how I see most of these kids from around the world, around the country. They usually present with a genetically confirmed diagnosis of Prader-Willi syndrome. So this little girl is 9 years old. She came from an outside facility after years and years of trying to sort out what her issues are. She comes to sleep clinic for daytime sleepiness and snoring. Her other sleep symptoms include snoring, pauses in breathing to the point where mom props her up with several pillows, daytime sleepiness to the point where at times she would rather go to sleep or take a nap instead of going out and hanging out with friends or family functions. Restless sleep to the point where her blankets are on the floor, the pillow is not looking like a pillow, it looks more like a punching bag, and significant behavioral problems during the day, particularly at school. Her medications are quite simple: growth hormone supplementation and a multivitamin. So overall, her past medical history that we know of is mainly the Prader-Willi syndrome, and no other pulmonary related issues like aspiration, or at this time, obstructive sleep apnea. Her physical exam shows +2 tonsils, slight micrognathia, which means her chin is slightly smaller and it's receded backwards a little bit. She has generalized overall low tone or hypotonia. And we use in the clinic currently validated scales to measure how sleepy they are so we can compare and contrast as they come into clinic. And that's the pediatric daytime sleepiness scale. And so her scale was scored as a 22. Anything over 15 is significant daytime sleepiness. So based on those symptoms, I referred her for a sleep study. This was back in 2020. Her obstructive AHI, which is the number of episodes of apneas and near apneic episodes per hour of sleep. So it was 25. The American Academy of Pediatrics considers 1 per hour as abnormal. So as you can see, 1 compared to 25, this is pretty significant and is considered severe obstructive sleep apnea. She had a central apnea index of 2.3 per hour. That's the number of central apneas per hour of sleep. And so it's not necessarily very high, but she has some. The oxygen nadir, or the lowest that the oxygen saturations are, is about 78%. So that's very low. And the maximal transcutaneous carbon dioxide values was as high as 51. Normal is about 35 to 45 millimeters of mercury. So overall, we know she's struggling while she's sleeping in terms of breathing. So as a result, because it was so significant, I referred her for a CPAP titration study, which is a sleep study with a CPAP mask. And basically, we figure out, based on the several pressure settings that we studied in the laboratory, what is the best pressure setting to treat the obstructive sleep apnea and get her the good restful sleep that she needs. So we started the CPAP therapy in clinic, and over the course of 6 months, she demonstrated great adherence, was able to use it at least 8 hours a night, no needed to have tweaking of the settings. Mom said that there was slight improvement in the overall daytime sleepiness, so her score went from 22 to 17, so not terrible, but she was still having a little bit of trouble at school. And also at this point, I referred her to the ears, nose, and throat doctors or otolaryngology to assess her airway, to see how much low tone of the airway she might have, whether or not her tonsils were really significant in contributing to the number of apneas that she had, as well as whether or not that's also contributing to our adenoidal, if her adenoids were big, also to be considered at this point. All right, so we're going to pause. She's going to use her CPAP for a little while, and then we'll get back to the case later on in the talk. And so why should we care about kids sleeping? I mean, we spend a half of at least a 24-hour period thinking about sleep or actually sleeping, right? Kids are not just small adults. It's the mantra of pediatrics. Everything comes in strides when it comes to kids, and the amount of literature and data that's out there. And that's true for sleep medicine as well. In basic terminology, there are 4 stages of sleep, and it's divided into non-rapid eye movement sleep versus rapid eye movement sleep. Non-REM sleep includes stages 1, 2, and 3. These are the lighter stages of sleep as you're falling asleep. Stage 3 is important for Prader-Willi in the sense that during stage 3, growth hormone is released. And so since Prader-Willi syndrome is known to have a deficiency in growth hormone, it is known to have, they're known to have a smaller amount of slow wave sleep. Rapid eye movement sleep is very important for growth. It's important. It's the dream state. It's the most metabolically active form of sleep in comparison to while being awake. In general, every 90 to 120 minutes, you'll have a REM cycle. And again, it's essential for learning and memory consolidation. So when we talk about good sleep in general, we talk about the timing of sleep. So do they sleep at night? Do they sleep during the day? Are they a shift worker? Are they not a shift worker? The amount of sleep, do they get 4 hours of sleep on an average night? Do they get 7 hours of sleep, 10 hours of sleep? What is the proportion of sleep? So do they get a lot of REM versus non-REM? Do they have the expected amount of non-REM versus REM sleep? And then continuity. Are they getting this type of sleep only during the weekday, and then on the weekends they have a different schedule and therefore their sleep quality is different? So we look at all of these things, and then we put it into a table or a map, if you will. We call this a hypnogram. And on the y-axis, you have awake, you have REM, which is these dark bold lines right here, and then the different stages of sleep. And then the x-axis here is the number of hours of sleep. And in a typically developing child, what you'll see is the first REM cycle is very short. It's not as dense. And you go through all the different stages, 1, 2, 3, and then you go into another REM cycle. And as the night progresses, you'll see longer and more dense REM cycles. So here is a child with PWS. And as you can see, it looks totally different, right? You'll see that the REM cycles at the beginning of the night are very short, but you can see a lot of these in comparison to what we saw in the previous slide. The other thing about PWS patients is that they have a lot of sleep fragmentation. They're waking up a lot, they're tossing around a lot. They have very little slow wave or N3 stage sleep as well. And as a result, this is what contributes to the sleep problems that brings them into our clinic. In general, the sleep center is in the suprachiasmatic nucleus. It's this really, really tiny pink dot that you see right there. As significant as sleep is, it's very, very small when you compare it to the size of the brain. But the significance of this is that it's right where everything else is located as far as Prader-Willi syndrome goes. And so growth hormone regulation, your sleep cycle, your breathing, all of that is regulated in the vicinity. And so no wonder a lot of things are related to sleep. So poor sleep in children, we know at least 25% of typically developing children experience difficulties with some aspect of sleep. I think this number is much, much higher because there's so many other complications and comorbidities that occur and are linked with PWS that sleep is not always the first thing that most people recognize. And so I suspect that number is much, much higher. And as we have gatherings and discussions about this, I'm hoping that that increases awareness and we actually acknowledge that this number is much higher. There are some surveys out there that show that, at least 61% of PWS kids have problems with sleep. And so that's almost double, if you will, in comparison to typically developing kids. So when you have poor sleep, what happens? In adults, we have trouble thinking, we might be sleepy, it might impair work-life balance. In children, it goes way far more into depth. The sleepiness impacts their cognition, their overall development, and their behavior, and in addition to dysregulation of their affect or mood. And that's separate from just PWS in general, but this is also in conjunction with the fact that you're not getting good quality sleep. As a result of the daytime sleepiness and the cognitive impairment and dysregulation, you also have problems with learning. So therefore you have problems in school. That can also be social dysfunction with their classmates. This also impacts health outcomes, cardiovascular in the setting of high blood pressure, having a slightly higher heart rate at baseline, neurologic issues. So some folks have seizures. And so if you're not sleeping well, that lowers the threshold of seizures and you're more likely to have more seizures in comparison to someone who has a history of seizures and is sleeping well. Overall, this impacts the caregiver. They're drained. They are pulled in so many directions with just regular life. And then all of these other problems that happen, they themselves are not able to take care of themselves because their child is not sleeping. So therefore the caregiver is not sleeping, or the patient is waking up other folks in the home and therefore disrupting the overall balance at home, and thus overall impacting overall quality of life. Okay. So I mentioned top 3 common sleep problems in PWS. What are they? One is sleep disordered breathing, otherwise known as obstructive sleep apnea. And I'll tell you why I say sleep disordered breathing in the next few slides. Chronic insomnia, which means having trouble sleeping or falling asleep greater than 3 months time. And then excessive daytime sleepiness in the form of narcolepsy-like features or hypersomnia. So we'll talk about all 3 of these one by one. And again, this is completely informal. Please interrupt if you want to, if you have questions that you'd like for me to address. So as a sleep provider, there's two resources that we use. One is the American Academy of Sleep Medicine manual for scoring a sleep study. And then over here on the right, the International Classification of Sleep Disorders. And this is what we go by as far as defining what sleep disordered breathing is, what narcolepsy is, what other sleep problems there are. When we talk about sleep disordered breathing, we talk about many things. One is we talk about obstructive sleep apnea, where there are pauses in breathing secondary to something blocking the airway. Sleep-related hypoventilation, which means that during breathing, the CO2 values are high when instead of blowing off the CO2 when you normally, as a normal function, you're retaining it and thus impairs how your overall function is when you wake up from sleep and everyday activities of living. Sleep-related hypoxemia disorder are the patients who have low oxygen levels at baseline when they're sleeping, and it's not related to obstructive sleep apnea, but it's a distinct category. Most likely, these are the patients who have lung disease of some sort, asthma, chronic lung disease, prematurity, interstitial lung disease, et cetera, et cetera. And then you have this whole category of central sleep apnea syndromes. And so everything overlaps with one another. So you can have a little bit of central sleep apnea, a little bit of obstructive sleep apnea. You can have all three of these, all four of these, all at one time. And so the basket terminology that we use is sleep disordered breathing. In PWS, though, obstructive sleep apnea, or OSA, and central sleep apnea are known very well. So when we talk about sleep disordered breathing in PWS, majority of the patients present with snoring, pauses in breathing during sleep, apneic episodes where the parent actually has to stimulate the patient to, or the child to wake up, choking or gasping for air during sleep, restless sleep. They're tossing and turning a lot. They're on all different positions because they're trying to keep their airway open. And then excessive daytime sleepiness, just because their sleep is so fragmented, the brain is trying to keep them awake so they can breathe accordingly. And so they have daytime impairment. So there are some tools that we use to diagnose sleep disordered breathing. One is history and physical exam. And then the second is a polysomnogram or polysomnography, or also known as a sleep study. And so pediatric polysomnography, even it's just like the word, it's super long, it's very complicated. It doesn't hurt per se, but it's quite intense in the sense of the number of leads that they put on the scalp. They put stickers by the eyes. They have abdominal and chest belts. They have a little plastic cannula that sits right at the base of the lip that goes into the nose. That measures airflow. There's a microphone. There's some chin stickers. I mean, it keeps going, right? And so just expecting a 2-year-old or a 3-year-old to go through all this is pretty extensive. So when we go through one of these, we really want to make sure that we ensure that we give them a good experience, number one, because most PWS patients need to have more than one sleep study in their lifetime. And two, to make sure that when they go through all of this, that we actually collect the data that we need so that we can help them and get the correct treatment going on. In addition to the fact that there's stickers on the legs and on the finger, we're measuring oxygen, we're measuring movements. Everything is video recorded. So if there's seizure-like activities happening during sleep, all of that can be monitored. All right, so once we categorize that the patient has obstructive sleep apnea or central sleep apnea, what do we do with this? Sometimes we use oxygen. Oxygen, particularly in the babies. So when they're born, they're very floppy. They have trouble with feeding. There's not an appropriate size mask that will fit over the nose of these babies. And so oxygen is one way that we kind of get by until they're a lot older. Positive airway pressure therapy, it can come in the form of CPAP, BiPAP. I'm using something called volume assured pressure support, which is a newer modality in the Prader-Willi population that I'm using. It's not always our first choice, but this is a different mode of ventilation. Same way you wouldn't know if you were on CPAP, BiPAP, or VAPS. but the difference is CPAP has one single pressure setting and it's going all the time. Whether you're inhaling, exhaling, it doesn't matter. BiPAP, there's two different pressures, one while you inhale and one when you exhale. Volume assured pressure support is great because it gives me a range. I use the patient's body weight and calculate how much volume the lungs need to expand. And what I like about this is as these PWS kids grow, their tone changes, whether it's for the better or for the worse. The machine will give that support regardless of that change. And so I don't have to make a lot of adjustments, which means I don't have to bring them to the sleep lab as much. And it's a little bit more efficient and easier for families to use at home. Sometimes we use medical management. Oh, go ahead.
Sorry, I was just gonna ask a quick question.
Please.
Do you see any difference in compliance based on using the VAPs instead?
So I don't have any data.
Okay.
I only have experience based on this.
Yeah.
Like I said, very little data in general, and then to the point that this is newly applied for PWS patients. I usually implement this very early on, but a lot of patients, what ends up happening is they get a cold, they get hospitalized, they're in the ICU, they're on a ventilator, they get removed from the ventilator and they're placed on this mode and then sent home. And
Okay.
so it's much later down the road versus
Mhm.
me so what I try to do is capture it before they get hospitalized, before they get to that point. And so I want to say yes, but I can tell you all of these are challenging. And the reason for that is it's non-invasive. It is over the nose, it's over the mouth. Sometimes depending on the body habitus as well as the risk for aspiration. Sometimes remember the masks are not all approved for pediatric patients. Not all of our PWS patients are the typically developing basic morphology, like facial features that would fit these masks. So part of the problem is just finding the right mask.
Mhm.
And then let alone understanding that the straps have to be in a certain way and understanding that I have to wear this. I mean, just understanding the whole concept is a lot for these guys.
Yes.
We have adults that aren't even adherent to it, right? So, and we're expecting them to. So there's a lot of challenges. I am collecting data on this to see if there is, I actually submitted a case report to the Journal of Clinical Sleep Medicine with the use of this. So hopefully you'll see more and more of it. I
Great.
brought
Thank
it up for that particular reason was that it's new and not new in the sense of ICU care. It's new for our PWS population.
Thank you.
Sure. Was there another question? Okay. Um, Medical management, sometimes patients they just have mild obstructive sleep apnea, or they have a lot of issues with adhering to their CPAP. And, the only thing that that they're able to tolerate is a nose spray and some medication to kind of help shrink some of the nasal tissues. And that's all we can get by. And it's pretty mild, so it's not worth the fight. And then I always send these kids to the ears, nose, and throats specialist, not always for surgery, but to make sure that there's no other anatomical abnormalities. So yes, tonsils, adenoids, yes. But what about sinus disease? What about, a deviated septum? What about tongue tied in the little itty bitty babies? When they're first born, they're having feeding issues, and the first thing everybody says is, oh, you know what? They're a very sloppy eater, they have low tone. Are they tongue tied? And maybe we need to fix that problem before we can actually allow them to grow and breathe appropriately. Okay, so that was sleep disordered breathing in a very quick overview. I'm going to move on to chronic insomnia. So insomnia in general is categorized between acute and chronic. Acute occurs within less of a 3-month period. So an example would be a traumatic experience and they just have troubles adjusting to the change. New caregiver, sometimes we see this when a school starts, first time they're going to full day kindergarten or full day first grade. You can see it just for a few months and then everything gets better and it's not an issue. And then you have chronic insomnia. That's more than 3 months. This is about 29% of PWS patients that experience some form of insomnia, meaning they have trouble they have early morning awakenings, they fall asleep fine, but they wake up earlier, like at 3 or 4 in the morning, and they can't go back to sleep. Fragmented sleep, they're tossing and turning around a lot, or they're just wide awake and they're just laying there. Frequent naps at unusual times. So this is a challenge because you'll see later in the talk, we'll talk about narcolepsy, but napping at 3 or 4 in the afternoon pushes their bedtime a lot later. And so then they're going to bed at 11. But then if they have to get to school and get up in the morning by 6:30, they're not getting the full amount that they need. Difficulty falling asleep and staying asleep is very common. Not getting enough sleep in general because of all these other issues that are going on. And then as a result of not being able to sleep at night, having excessive daytime sleepiness. So there are some tools that we use for chronic insomnia. First thing we do is history and physical exam to make sure that there's no underlying medical conditioning contributing to the insomnia aside from PWS. We tend to go to a sleep diary. This is an example from the American Academy of Sleep Medicine, where it kind of gives us an opportunity of looking at the sleep pattern over 14 days, 20 days, and looking for specific patterns. And then the third thing that we sometimes use is something called an actigraphy. This is the glorified Fitbit, medical grade Fitbit, if you will. And so this is one of the older versions of it. But basically, it's based off of movement. And so the newer technology now uses heart rate and body position and things like that, and they're much fancier now. But for the most part, most of these will record whether or not you're sleeping. Now they can record what stage of sleep you're in. The ones that we use in our lab right now is just telling you, is there sleep or no sleep? And so here is an example of a week of sleep recorded. And you can see these teal colored areas are sleeping. All right. So some of the things that we talk about when you first come in for a sleep evaluation for insomnia is we make sure we maximize their sleep hygiene. And when I'm talking about sleep hygiene, I'm talking about maintaining a consistent routine, bedtime routine. And it doesn't have to be complicated. It can be as simple as brushing your teeth, changing into your pajamas, saying saying your prayers and, reading a story and saying goodnight. Limiting the amount of blue light exposure. So the tablets, the iPads, TVs, things like that, turning those electronics off at least, I say 2 hours to patients, but ideally 1 hour is best. If you say 2 hours, then eventually you'll make it to the 1 hour mark, right? Because life is busy. So 1 to 2 hours before going to sleep, and then trying to avoid naps depending on the age of the child and what is really going on medically. Naps may actually hurt you and not allow you to sleep when you need to sleep. So we start there. Sometimes we refer our patients to our sleep psychologist who will work with you one-on-one to kind of change and modify the way things are. A lot of our kids know routine, they have a routine of their own, and trying to deviate from that can be very challenging. And so our sleep psychologist is great. She will work with them as often as you need to kind of break some of these behaviors and allow them to adjust to the change as you're going forward and trying to adjust their sleep habits. Melatonin is over the counter. It's not FDA regulated. There's lots of formulations, tablets, sprays, gummies, chewables. It can be mixed with other herbal remedies, so be careful. Just because it's over the counter, it doesn't mean that it doesn't have side effects. I have not seen anything in the literature as far as side effects in the PWS population. But in typically developing children, there are reports of early lactation in pre-pubertal girls in high doses of melatonin. So we have to be careful on how much we take. But melatonin is good for those patients that have trouble falling asleep. It's not great for those that can't stay asleep. So it's only a certain subpopulation that this would be helpful. I prefer only using the liquid version. It's the purest form. When you put them in different formulations like a tablet or a Solutab or something like that, you're changing the actual molecule in a way so it's not as effective. And timing and dose are both very important. So the lower the dose, the better. So usually on the bottles, it says 1 to 3 milligrams or 5 to 10 milligrams. You just need 1. Even in PWS kids, 1 is enough to know for sure whether it's going to work or not. And it's usually, I tell them to give it 2 hours before bedtime. And I say 2 hours because that's usually when the physiologic clock will kick off and allow them to sleep. So it gives them a little bit of time for the melatonin to kick in. Melatonin is also not a forever drug. It is not something that you take forever and ever and ever. It actually, if you take it every single day, it'll stop after a few months, and the body takes over. Even in PWS, the pineal gland, which produces melatonin, is functional. There are studies there that show that. And so you don't need the biggest bottle from Costco to treat chronic insomnia, no matter, it's just a short period of time. There are other non-FDA approved medications that we take from the adult world. Very little literature to support it. The problem with a lot of these non-FDA approved medications and not supported by the American Academy of Sleep Medicine is the fact that there's a lot of side effects with them, and we don't know what the long-term outcomes are for these kids as they're growing and how it affects them. So we do strategic planning and counseling when we're trying to prescribe these medications, because at some point, safety is a big issue. If your child is waking up at 2 or 3 in the morning and they're roaming around looking for food, it's not the best thing if you have steps and things like that. And the fact that you have to work the next day and you have to maintain their safety, sometimes a sleep aid is helpful. And so that's where we come into play and kind of guide you as far as what other recommendations there are out there. Okay, so going back to our 9-year-old little girl with PWS, she comes back about a year later with good adherence, but mom says her symptoms are kind of worsening, even though she's using her CPAP almost regularly. Mom, initially, when I referred her for an evaluation by ENT, she was not ready for anything surgical. She just assumed that that's all they were going to do, and so she held off. But mom was ready now to say, okay, I'm just going to go listen to what they have to say. At that point, they recommended to have her tonsils and adenoids shaved. Usually they're shaved because in order to minimize the amount of bleeding and decrease the recovery time. And so after the surgery, she comes back to me. We repeat our sleep study about 4 months after all the healing has been completed. And now, if you remember, her obstructive AHI was about 25 initially, and now it's 12. So it went down by 50%. She no longer has any central apneas. And her oxygen was as low as 90%. So much better compared to before. It was in the 70s before. And her CO2 values are no longer in the 50s. They're now in the high 40s, which is where we want them to be. But over 10 per hour of having episodes of near apneic or apneic episodes during sleep is pretty severe, still in the severe category. And so I told the family to, let's take her back to the lab. Let's retitrate her to see, maybe she needs more pressure. Maybe her tone has worsened over time, and maybe she just needs more pressure. So we did that. I adjusted her CPAP settings, sent her back home. And so after 3 months of using it, mom comes back and says, I'm doing great. She is using her CPAP every night, but she's still sleepy. Not only is she still sleepy, now she's falling a lot. And I don't know if it's because she's sleepy or not. And maybe she just doesn't understand that she has to stand and watch her gait. Mom also notices that a couple of times when they're talking about meal prep or when she's helping out, she'll have twitching of the corner of her mouth. So at this point, I referred her to the sleep lab again, but this time for a workup for narcolepsy-like features. All right, so what does that mean? So here we're going to talk about excessive daytime sleepiness in the form of narcolepsy-like features, as well as hypersomnia. First, what contributes to excessive daytime sleepiness in general? And so a lot of things, especially in PWS, the obesity and the different chemicals that in the body, having low tone, having mood disorders can affect how well you sleep, as well as the other way around. You're not getting enough sleep as a result, so therefore you're sleepy. Endocrine abnormalities, so I mentioned growth hormone deficiency, so therefore you're not having as much N3 sleep, and so therefore it can contribute to not having good quality sleep. If you had sleep disordered breathing, You could have narcolepsy-like features, and then you could also be on medications like seizure medications that can contribute to daytime sleepiness. So I'm going to focus the next few slides on narcolepsy. So narcolepsy is characterized by excessive daytime sleepiness or quick periods of when patients will just quickly fall asleep and take a nap in an instant. It's also categorized by cataplexy, which I'll talk about next, sleep paralysis, which is basically your eyes are open, you can hear everything, but you can't move. And this occurs when you're trying to wake up or as you're falling asleep. Hallucinations, seeing things or hearing things as you're falling asleep or as you're waking up in the morning, and then sleep fragmentation. In typically developing children, there are two types, type 1 and type 2. Type 1 is with cataplexy, and type 2 is without cataplexy. For the diagnosis of narcolepsy, the gold standard, which we don't do, we do it mostly for educational purposes, but we measure the level of hypercretin in the cerebral spinal fluid. And based on the measures of how much hypercretin is in the cerebral spinal fluid, that gives you the diagnosis as well. Again, it's very difficult to do in the pediatric population, so we don't really do it as much. We diagnosed narcolepsy by an overnight sleep study. Actually, I lied. We diagnosed it with an actigraph. So the actigraphy, the glorified medical grade Fitbit, you wear that for 14 days. Then you come into the sleep lab for an overnight sleep study. And then you stay all day the next day, and you undergo a mean sleep latency test. A mean sleep latency test is a test that measures how sleepy you are by a series of naps. So you undergo 5 naps. In between each nap, you're required to stay awake, and we measure how quickly you fall asleep. If you have a time that's less than 8 minutes on average, then you have the diagnosis of narcolepsy. Okay, so I mentioned cataplexy. Oh, I did not know that was going to happen. So cataplexy in general is sudden episodes of muscle weakness or loss of tone that is brought on by strong emotions. In typically developing children, it's usually laughter, sometimes anger, extreme anger. In PWS, though, it could be anger, it could be laughter, it could also be food. It could be revolving around food as well, because we know that they have hyperphagia. They have the tendency to look for food and search for food. And that alone can cause a heightened emotional state and thus, as a result, contribute to muscle weakness. The problem is when they go through this, it's not classic. It could be anywhere from a behavioral outburst or a meltdown to episodes of just leaning to one side and just, hanging onto the wall for a second or two, or laughing. So it could mimic a seizure in a way. Eyelid twitching or facial twitching, drooling because you lost the ability to keep the secretions inside your mouth. And so it looks like you're drooling and not able to control your saliva. And like this little girl, tripping episodes. So they're constantly tripping over their feet. And so it's not because, they were, careless. A lot of times that's what ends up happening is they're considered to be careless or, they're just bumping into the walls all the time and not really recognizing that these are episodes of cataplexy. Lastly, staring spells. So this is difficult. Sometimes what happens is in the setting of strong emotions, the child could just stare out off in space, and similar to a seizure. The difference between cataplexy and seizures, though, is that during cataplexy, they may not be able to move that body part or move at all if it's generalized, but they can hear, they can see, they can hear, they know the actual experience. They may not be able to tell you because of the maturity of the child. Whereas in seizures, you don't know it's coming. You don't know, you lose consciousness. And a lot of times there's a postictal state where they're sleeping for a little bit afterwards. And cataplexy, life goes on. The episode ends, it's very brief, and you move on with life. I put this here as a summary in case anyone was interested, but the differences between narcolepsy type 1 and Prader-Willi syndrome. The average time is almost a little bit lower in comparison to, or a little bit higher in comparison to narcolepsy type 1. Although I think the literature is going to be controversial because lately I've been seeing 2 minutes, 3 minutes, 1 minute in this patient population. So I think we need more data as to say what is the actual mean time for these guys to fall asleep in comparison to typically developing kids. Both groups have cataplexy. Narcolepsy type 1, though, there is a genetic disposition, which is the HLA antigen. For PWS, it's not associated with narcolepsy. And so those patients, I think there's more to come as far as what contributes to the narcolepsy-like features. And that's the other reason why I don't say narcolepsy, because narcolepsy is defined with this genetic abnormality versus PWS is associated with narcolepsy type features or like features, if you will. Sleep paralysis is not very common in PWS, but it is in narcolepsy. Hallucinations are hard because sometimes you can have hallucinations in general with PWS, especially if there's other psychiatric conditions associated, but it's very common in narcolepsy. Sleep fragmentation is very common in both groups. And then as far as conventional therapies to treat the daytime sleepiness, in PWS, it's very challenging, as you can understand. There's very limited data as to what works. And so sometimes we have to revert to using some of the conventional therapies out there first to see if it's even beneficial. So there are, like I said before, there's very limited FDA-approved modalities that we can use in PWS, and even in PWS patients, using medications like modafinil or even stimulants or ADHD medications to treat narcolepsy, they don't always work, and there's again significant side effects when you're talking about that. We do recommend short scheduled naps throughout the day, especially if you have something important coming up. So when I talk about short, I'm talking about less than an hour, sometimes less than 45 minutes. And that's enough to allow them to feel refreshed after they take their short nap and go about whatever task that they want to do. Usually I will ask families to do this if they have a family event or soccer practice or something like that. Take a nap in the car on the way there, and then they're just refreshed and energized, ready to go. And then, like I said before, wake promoting agents, you'll hear about pitolisant out there that's under review, as well as modafinil. There's Xyrem and Xywav. Again, not really ideal for our PWS patients. All right, so I'm going to go back to our little girl with PWS. I sent her to the lab because I suspected that she might have narcolepsy type features. So the actigraphy, or the glorified medical Fitbit, confirmed that she gets 7 hours of sleep, but it's extremely fragmented. Her sleep study while wearing CPAP showed that her sleep disorder breathing was adequate. But interesting enough, there was one sleep onset REM period recorded. And so this is a measurement of how quickly you go into REM sleep. PWS patients go into REM sleep pretty quickly, just like a newborn goes into REM sleep. And so we count how many times that happens to help us with the diagnosis. And then the mean sleep latency test, she fell asleep within less than a minute. So 0.8 minutes, and she had 2 sleep onset REM periods. So technically, she has narcolepsy secondary to a medical condition, PWS. And so here, I know it's a lot, but I just wanted to show you, this is the hypnogram that I showed before, but these are the naps. And as you can see, the amount of REM sleep that she had during the day, it's very short. And these are the wake periods. She stays awake, has no issues. But you can see in between these naps, it's very little sleep. It's very fragmented. And so she fell asleep in REM sleep at the beginning of the first nap and then at the very end. So we wanted to try some treatments to help her stay awake so that she could go to school and learn and do all the things that that she wants to do. But due to insurance issues, I had to start her on ADHD medications in the form of methylphenidate, extended release. But as a result of that, she lost quite a significant amount of weight. And so and she was quite irritable when she was taking it. So we had to switch her to modafinil. Modafinil was we gave it to her in the morning, and then she took another one at lunchtime for school, because these kids metabolize these drugs pretty quickly. And it's usually, if you're a shift worker, you just have to take it once through the shift and you're fine. But this, for PWS and for those with narcolepsy, you have to do twice a day dosing. And it's not the conventional morning and night, it's usually morning and lunchtime. In addition to the medication, we gave her scheduled naps. So at lunchtime, she takes her medication, she takes a 20-minute nap, eats lunch, and she's able to get through the rest of the afternoon without falling asleep. Her daytime sleepiness improved. The scale went from 22 to 12 now, and she remains on CPAP and is doing great. So over the course of 2.5 years, the diagnostic workup and our treatment towards not just treating the sleep disorder breathing, but it also identified narcolepsy type features. And that was all with the chief complaint or initial presentation of excessive daytime sleepiness. So as you can see and understand that not everything is straightforward when it comes to symptomatology, which makes it very difficult for families to cope and figure out what they need for their child. So I stress the frequent follow-up appointments. We have screening tools. Some of them have to be improved so that we can identify what works and what doesn't work in this patient population, so that we can improve the overall outcome in the PWS community. So something I just want to highlight, it came out at the beginning of the month, is to recognize that the American Academy of Sleep Medicine understands and recognize that PWS is a patient group that we need to focus on. And so they have practice parameters and recommendations for clinicians as far as what we should follow to maintain standardization. And so in this article, there was a little blurb on PWS and how common excessive daytime sleepiness is. And, what does the cerebral spinal fluid look like in PWS? It wasn't a long blurb, but the mere fact that it made it to the journal is a milestone. So in conclusion, sleep problems are common in children with PWS. It's not often recognized because there's a lot of other abnormalities and comorbidities that are associated with PWS. And so that also leads to having sleep problems that can vary in presentation as well as in severity. Sleep disorder breathing and insomnia are common, but excessive daytime sleepiness may be under-recognized and may also be as of equal importance when identifying sleep problems. We need more research. We need more data gathering regarding the natural history of sleep in this patient population to help us guide treatment options and just standardization of care. When should we get a sleep study? How often should we get a sleep study, et cetera, et cetera.
All right. Well, thank you for being with us. This was very helpful. I appreciate it.
Feel free to reach out with questions as well. Happy to help out any way I can. Thank you so much for the opportunity.
Thank you. Appreciate it.